And we're beginning. Somebody wants me. Okay. Sorry. Now, uh, I'm going to give you some information about the practical next week. I put out some bones. If anybody wants to stick around and take a look at them, they're fine. There's a cupboard full of them. Uh, I, other days that I could do this, I could certainly make myself available Friday from like 2 to 3. We could conceivably, I could have the lab open Monday, again 2 to 3, even longer because I have a lab. There's nobody in here on Friday, but so I have a class between 1 and 2. So anytime after that, same thing on Monday. There's nobody in here. I have a class that starts at between 1 and 2 next door. So I mean, I could easily open the lab up when that at the start at 1 o'clock, or and keep it open even when my lab is going on. It's not, you wouldn't distract them if you were in the back looking at stuff like that, or taking it outside and looking at a chair or over at the gym. Okay, so there'll be ample opportunity if you wish to do it then. That's fine. So, and I'll get onto that. I just want today's presentation is about joints or articulations. Where are you in AP1? Are you into that yet? You already started to talk about that. You would figure. So I'll give you my perspective. I don't know how in detail it's going to be. We really don't have a section on that from a practical perspective, but I thought I would share what information I can with you about that and really try to point out the nuances of the major joints. You haven't got into the muscle physiology part of the program yet. That's about right. The muscle and nerve physiology takes up the largest nugget of time, and we're roughly at the halfway point now. And that, to me, that's the hardest part about AP1 from a lecture perspective. Okay, very good. So I know where you are. So I'll give you my impressions of this. And you probably use the same or different PowerPoints to explain this. And so if it's rehash, it's rehash. But there's never anything wrong necessarily with rehashing stuff like that. The first idea is that the notion that joints have to move. They don't. A joint is where two bones come together. Whether they move not at all, whether they move a little, whether they move a lot, there's a certain degree of variation that's associated with that. So we classify, and you'll see that we do this a lot. We classify things structurally and functionally, and in joints it kind of comes together. So the question is, and it's interesting, that what makes the joints move the least are fibrous joints. There's 3 of those. Cartilaginous joints, there's 2 of those, move a little. And synovial joints, which is when you think about a joint, moves a lot. I had a ton of experience with regard to these things. We did a lot of bone and joint surgery when I was in practice. So I have an extensive amount of familiarity with this material. So the first thing is the categorization. So they may ask you to do this lecture-wise. I think it's pretty straightforward. The fancy classifications are based on movement. Syn, arthro is obviously referencing joints. So, for instance, when we cut into a joint, it's called an arthrotomy. Okay, when we fuse 2 bones together so a joint doesn't move, it's called an arthrodesis. Okay, so when you remodel a joint, let's say you're inserting a new knee or a new hip, it's called an arthroplasty. Plasty means to remodel. Okay, and that's called an implant arthroplasty. So, the terminology is fairly straightforward. So, syn, without movement, amphi, some, diarthrosis, don't know the derivation of that, freely movable. So they look at all those things. The only ones that have a, quote, joint cavity are the ones that move. The other ones don't. The other ones, it's just the bones are together, and it's what's sort of holding them together, what's stuck in the middle. So they're not designed necessarily to move. And so the fibrous ones are the ones, and you saw a bunch of those already. If you take a look, I'll just flip out of that for a second because I cooked one of these. You remember that slide when we were looking at the sutures? And I'd be familiar with that. Okay. All of those sutural joints are really fibrous joints. When the baby's developing in utero or when the baby's born, those fibers are relatively far apart. It facilitates vaginal delivery, and the head will sometimes even be slightly distorted. It flips new parents out who aren't ready for that. Pardon me. And the reality is we call them soft spots. And because there's sometimes fluid and they would pouch out, the anatomists name them little fountains, but then they use the term fontanelle. And so by about age 2, they all close. Those fibers get basically shortened as the bones enlarge, and they hold them together. So they bear the name sutural joints because in the old days when somebody was cut, they just sew them together. And it was a very irregular. It looked a little bit like railroad tracks. And that reminded that. We didn't have the cosmetic or plastic techniques that we employ today. And there's a whole science behind that. If anybody of you are going to go into a field where you're going to be observing or participating in a fair amount of surgery, it's very fascinating, what we call the plastic approach, trying to make things look cosmetically, particularly when you're working on areas that are exposed. So, I mean, there's a whole lot of nuances to that as well. So I figured I'd start with that little nugget and go from there. So let me get back to where we were. So you have the sutural ones, rigid, once they shorten as the bones grow, and what happens, they turn into bone eventually. So there's not the fibers themselves, and there's a fancy name called synostosis. Not a big deal for you guys. Just looking like that. And so it's this sawtooth appearance that almost looks like a serrated edge. And so there's not a whole lot to it. Sometimes we'll see bones connected together. This one's very famous. One of the things you'll see on the practical, I probably have one in here, is a tibia and fibula together. Okay. Cut me off and I had bones in me. Breathing a bone out of Philadelphia. It's a true story. Okay, here we go. Tibia and fibula. So the joint they're referring to is down there. It's called the inferior tibiofibular joint. That's the joint that kind of locks the tibia, the large one, and the fibula, the small one, and holds the ankle in place, just like it does with all these wires. You hear about the high ankle sprain. That's what that is. High ankle sprain happens when you can't do it with the wire. And the ankle twists like that. And that's the way most of the time when you sprain an ankle, you twist it like that. Called an inversion sprain. This is a third foot. And what it will do is that the dome here of the talus will jostle those apart and tear them. A typical ankle sprain that most of us get is goes from the tip of the fibula here down to the calcaneus and sometimes it's the talus. And that's below, it really is almost below the ankle joint, really below. And that's a really nasty one. And those are tough to fix. They take a long time, and a lot of times for sure. So that's why when you hear about football players or other athletes, ankle sprain versus a high ankle, and typical ankle sprain might be a couple of weeks. High ankle sprain is 6 to 8 weeks. So, and here it depends on the amount of fibers that are there. Those are short, very little movement. Radius and ulna here, the upper extremity, fibers are comparatively long. You allow more movement. So a lot of times it's the relationship with the fibers that play a significant role with regard to that. There it is down there in living color. Okay, gomphosis, I think gums like teeth, basically a peg and hole. Hopefully none of you have had teeth other than baby teeth removed. But when they do that, the hard part about doing extraction is this periodontal ligament. That's the part that had to get a tooth out, things like that. Ugh. Ugh. And so cartilaginous, there's only two. The symphysis, very famously, is the cartilaginous disc in the pubic area. You remember we had those. We're looking at the pubic arch. That, you could distinguish between men and women. There's a certain amount of give with the cartilage. The other one is called a synchondrosis, and you'll even see that. Let's say where the ribs meet the cartilage that goes to the sternum. Epiphyseal plates, where bones are growing. So you did the bone. You already did the bone chapter. So the growth plate, right, in AP1, the growth plate is technically speaking cartilage. I personally don't think it's a joint. Understand that the people who write these textbooks and write these PowerPoints, it's more from an anatomical perspective than a clinical perspective. So it isn't quite the same. But what happens, the cartilage, when you reach bone maturity, as most of you have, more or less, okay, then that becomes really bone, and now it converts that synostosis. So there's a couple of these areas that you can see there. The symphysis, intervertebral discs, basically allow a certain amount of movement. Pubic symphysis, you can see those that are there. That's it. Everything else is moving. So moving joints are because of a variety of features. And you can see it on any one of these models, whether it's a real bone, not a real bone. But you can take a look at this, actual bones. Ends of these bones, feel the smoothness is here, let's say at the head of this metacarpal, basically proximal filament. They're covered in cartilage. Bones grow from a cartilage shell. What's left when the bone is completely formed is the cartilage at the end, we call it articulate. It's made of something called hyaline cartilage. It's beautiful, it's white, it's glistening, it's perfect. It's healthy. It's rough, irregular, soft, or hard, depending, and someone would want to look at it. I can't even tell you how many times I've seen this intraoperatively. So they're with very limited exceptions. These are synovial joints. What's unique about them is you have these smooth areas are not exactly in contact. There's a tiny space that can get bigger. It's filled with fluid. The fluid is called synovial fluid. The fluid is interesting. It's like a lubricating fluid. It's slightly viscous. It's a little bit sticky. You want to know. It's not like, if you think of lubricating oil, 3-in-1 oil you might use for a door that's squeaking, or even oil that you might put into a vehicle. It's probably not as viscous as they are. That means there's a certain amount of protein in it. And we look at that. Actually, interestingly, when we try to diagnose arthritis, when we're taking samples of synovial fluid, we put it on your gloves, and you'll kind of see how stringy it is. Now you can have like something like that with oil and you can pour it apart your fingers. So it's interesting. Those are little tests that we sometimes do in the process of doing an operation. Again, there's a lot of nuances with regard to this. What do I do with my arm? Okay. So, we've got my wonderful artwork. The cartilage is more extensive. It's not just here and here. It extends a little bit farther because there's a fair amount of excursion. What holds these in place, okay, and surrounds it with a very distinctive pattern, like that is called the capsule. The capsule is made out of dense, irregular connective tissue. It is sturdy. Okay. Most joints, the capsule is very sturdy. Some not as sturdy as others, and those are some of the nuances that we see with certain kinds of joints. The pattern is so distinctive that when we cut into a joint, we can actually see the fibers are there, and we sew it back together, we line up the fibers. Make sure that they come together. That kind of stuff. So you have it, and it goes top to bottom, side to side, all around it. When you study bone, you learned about periosteum, to be a name that's familiar to you, coating on the exterior of the bone. It continues into here, so periosteum would be here. Once we get to the joint area, it kind of lifts away from the bone, changes, and now this whole area is filled with fluid. It is very thick on the outside, and it's got a thin layer of what's called synovial cells. Simple squamous epithelial cells, they give off what we call secrete the fluid. So now you'll see some of them have extra little bits of synovial tissue surrounding tendons. They're called bursal sacs or tendon sheaths. I disagree with what they talk about with stability, but that's just me. Okay, we'll look at the different types of movements. They're fairly distinctive. It doesn't take long to look at that, and then you want to look closely at a couple of really important joints, mostly knee and shoulder. And that's really what today's presentation is about. I wish you could see it up close and personal, but we don't have, even if you dissected like we might do here, a cat, which I wouldn't do. I couldn't go home and face my cats. I couldn't. I think I had your Uncle Joe in the laboratory today. They'd be upset. And the one cat would be angry at me, and I don't want that. He's CIC, cat in charge. The dog's afraid of him. So they have the cartilage, they have the cavity, they have the capsule, they have the outer thick layer that holds it. The synovial layer creates the fluid, the nature of the fluid that's there. Different ligaments. This is when we get to the knee. The knee has all three of these. A ligament, in this case, the typical when you say the word ligament, it basically is a structure that's holding bones together. Not all of those ligaments are the same. Some sit outside the capsule. In the knee, what's called the fibular or lateral collateral ligament does. Some are incorporated in the capsule. Okay, we call that intracapsular. No, that's quote unquote capsular. And then in the knee as well, they have the crisscrossing cruciate ligaments that you hear so much about in sport. On the inside, those are intracapsular. The knee has all of these. And so they're easily discernible that way, and all the other stuff that's part of it. That's kind of what it looks like. So the joint expansion is wider. Joints have this inherent stretchiness. That's from that pattern. Because look at your elbow. When I do this part has to stretch, this part has to fold. And the same when I go the other way, when I straighten it out, now this has to stretch, and this has to fold. So what we see in the joint, and I can't draw it, it's a recurring pattern we see in anatomy. You see it everywhere. Fan folding. When in AP2, when you look at the heart, you look at the interior of the heart and the atria. It looks like little ripples. It occurs in the bladder. It occurs in the esophagus. Basically, in order to conserve space, when something is compressed, it folds in on itself. It's like one of those hoses that they always try to sell you on TV. That it looks like it'll fit in your pocket. It'll grow to like 50 feet. It's all kind of fold. You know what I'm talking about. Love those. It fan folds. And so the beauty of those little folds, okay, a fancy term we use for folding is plication. So the interior of the joint kind of looks like this. Accordion pleats. Okay? Every so often, you'll get a pleat that kind of goes the wrong way. All of a sudden, it's supposed to be going in here, and it juts out here, and stuff can get trapped in it. So the fancy name we give that is called a plica. You see them in the knee. So a lot of times when things don't fold properly, you have problems. First wife was doing dance, doing ballet. The kids were little, and it got one of those in her knee. So it's not an unusual sports injury. So what will happen is when it can't fold and unfold properly, it jams up. That's what pain comes. So there's a whole lot of stuff that goes on with that. I've had entirely too much experience with my daughter had knee surgery at 12. My middle son, who rides BMX bikes when he was little, backflips and stuff like that, dirt jumps, if you're familiar, like X Games stuff, just had 3 knee surgeries by the time he was like 18. Moral of that story is don't have children. Which my wife and I have 8 between us. So go figure. She's got 5, I got 3. Kids. Keep making the same mistake. There's a lot of fatty pads. These are also in the knee. Not the only joints. Your temporomandibular joint has that. your sternoclavicular joint. They have little extra bits of cartilage, and those discs increase what we call the degree of freedom. They increase mobility. The trade-off is stability. So in the knee, when you hear about knee cartilage, they're known as the menisci. Singular is meniscus. And they're very easily tearable. Very, very common injury in sport. Same thing when you dislocate your jaw. The most dislocated jaw that you have joint in the body is the temporomandibular joint. So people get, sometimes it's really a problem getting into clothes properly. It just slips out of positions because it's got this, the way I look at it, when you put stuff like that in, whether it's a knee or a shoulder or a jaw, that's more stuff to go wrong. We're fond of saying KISS, keep it simple, stupid. But that's not. So, and then you see this stuff, and you're going to see it in the shoulder. You see a ton of them in the knee. They are bursal sacs and tendon sheaths. They are containers, tiny containers filled with joint fluid that are buffers against friction and pressure. Okay? And whenever you have structures that rub together, these either are there to prevent problems or they can develop. So there's ones that are always there and ones that can develop. If you start a new job and you're doing a particular activity, you can get a kind of bursitis because you're using a part differently. And tendon sheets, anytime a tendon goes around a bend, going into your wrist, going into your ankle, going into your shoulder, it's got one of these sheets around it. You're going to see the most famous one of them all. That one is this particular tendon sheath. This is called the tendon of the long head of the biceps. It's a super stabilizer that holds your shoulder. It inserts up here on top of the glenoid fossa. The short head inserts on the coracoid process over on this side. So this fits in something that's in between. It's called the intertubercular groove. There's a greater and lesser tubercle, you might remember. There's a groove in between them. It sits in there. When somebody ruptures a bicep, like a football player trying to make an arm tackle and pushes it that way, it's not so much the tendon that ruptures, it's generally the sheath and the material called retinacula that's holding it in place. And generally you have to operate to try to basically create scar tissue to hold it into place. Very, very common sports injury. When we would operate in hands, wrists, and ankles, you had to be careful because the tendons are they're loaded. There's tension in muscles, okay? And so when a person's asleep and you're operating, you have to take that into account. Because if you shorten a tendon or lengthen it, you might have a finger that's, when they wake up, it's kind of up like this or down like this. Neither of those is good. You want just right. Not enough, too much, just right. Goldilocks, bears, too hot, too cold, just Goldilocks. You remember her? It's awful. We celebrate that. Oh, too hot, too cold, just right. What is she? Home invasion. She trashes it, goes into the bear's house. She trashes the place, breaks up the furniture, eats their food. And yet, she's famous. She'd be in jail. I really question that. So, a lot of those tales. Really? Snow White was in the woods with 7 guys, one of them named Doc. Are you kidding me? Would your mom want you? Go ahead. Hey, Mom, I'm going to go live in the woods with 7 little people. Sure you are. Dreaming. Right? Go ahead. You ask. Dr. Stein wanted me to ask you if it was okay for me to live in the woods with these 7 guys. Really? Yeah, we're all celebrating that. And I've done this routine for 20 years. It didn't just come to me. Rehearsed shamelessly in front of a mirror many, many times. I love them. Home invasion. I can't wait till I get to my granddaughter. I have to with her. Bursal sacs. This is a very famous one. It's called the subacromial bursal sac. The acromion process in the clavicle, the AC joint that's up there. Another one easily dislocated. Very, very common to get bursitis in there because you're using your arms strenuously. The things that make joints stable is this, by far and away, not this. I don't know if they're going to tell me it's the shoulder and the muscles holding the shoulder in place, I'll buy it. Knee, no. Foot, no. Ankle, no. It's all about the shape of the joints, not a minor role, and the ligaments that hold them in place. I don't know where they got this. It's just garbage. And they have a little laundry list of joints. We will not do it. Classic anatomy, when they teach muscles, they talk about origin and insertion. And the reason we don't do it anymore is they're really somewhat archaic. Origin theoretically is the bigger bone or the bone that doesn't move as much, and insertion is what it attaches to. Well, that's fine. If I'm grabbing a marker and pulling it like doing a curl like that, that's fine. Okay, origin here, insertion here for, let's say, the biceps brachialis. But what happens if you're doing a chin-up? I mean, then this is the fixed area, and flexing those muscles is lifting up your torso. So it works. We know that it works backwards. You can step on the gas, okay? You can flex your foot in that direction to step on the gas. But if you're going up to reach for something in a shelf, now you're doing the same activity, but the different parts moving. It's not the foot; it's the torso. So we call them attachments. It's a much more sophisticated way to look at this, and it looks at the different kinds of movement. I'll give you the quick. You probably had it. It's all about how many different axes or ranges or degrees of freedom. There's all sorts of different ways to express it. Classically, when you think about flexion and extension, it's one plane. It's a sagittal plane motion. Remember, first time we met together, we talked about the anatomical position. So that's sagittal plane, this plane that's coming in front of me. Most of the joints, when they say, so that's uniaxial. Non-axial are little tiny motions. They slip and slide or glide, typically flat surfaces, wrists and ankles, in between the vertebrae. There are so many little joints, when you add them together, you can twist, you're reaching over, even for somebody like me, reaching over and twisting to get something. There's a lot of motion that's occurring, even though those are little tiny joints that are all moving. Biaxial, two planes. The knee doesn't just flex and extend. What those discs in the knee allow it to do is to rotate internally. When you step down and put your weight on your knee and flex your knee slightly, it allows your thigh to rotate internally. That is an unlocking motion that allows shock to go directly up. When somebody who walks stiff-legged like that, the shock comes up this way and really hurts their hips. So mechanically, there are different changes that are there. And there's only two joints that work multi-axially. They are your shoulder and your hip. They are ball and socket joints. The shoulder has a tremendous amount of mobility. How do we judge it? You can move your finger in a circle. It's called circumduction. Okay. Opposing the thumb looks like that, but not quite. Okay. And you can do the same thing, although more limitedly, with your hip. So they just show you your wrist joints, and flexion and extension. Some joints are designed to hyperextend. Okay, obviously your neck, you can bring it back this way. You can't do it with your elbow because bone hits bone, and you would either dislocate it or fracture it, which is the difference. Same thing with your back. We always use the terms when we move in remember the frontal plane is going this way. So bring your arms out, bring them in, like that. It's called AB and adduction. Add and abduction sound too much alike. Down the road, maybe you've done it already, you'll hear about afferent and efferent. Afferent signals are incoming signals, efferent are outgoing signals. So we always pronounce that first letter if always confusion. But there's certain things when you're in this, when you finish the field, you're going to go into. Those are the little nuances that allow us to do that. So I can AB duct, I can AG duct, bring them in, I can even hyper like this. I can even do this frequently called galaxy. Galaxy. Never give up. It's sort of a cult sci-fi movie. It's very strange but funny. Okay, and rotation. Some people will hear internal and external are used a lot. In medicine, medial and lateral are used a lot in anatomy. So in medicine, like in orthopedics, you talk more about it's more about the usage. Okay, and so they use terms like internal and external. Well, medial and lateral are more pure anatomy. So when we were in anatomy class, we had to use medial and lateral. We were in clinical classes in orthopedics, they talked about internal and external. And supination and pronation, famously, hold your elbow at 90, palms down, pronating it, palms up, supinating it. If you're lying face down, you're lying in a prone position. If you're lying on your back, you're in a supine position. Same thing in your feet. If you flatten out your feet, you pronate them. If you kind of arch up your feet, you supinate them. We used to say flexion and extension in the feet, dorsiflexion, toes towards your nose, plantar flexion, pushing on the gas. Not hard. Like I said, inversion, eversion. The classic ankle sprain is you roll your ankle to the outside. That's an inversion sprain. You don't see it to the inside, you have less range of motion and more likely more serious injuries when it's like that. And jaw protractor retract. Same to you. 6 different kinds of joints in my classes when I do the lecture, which is it's unfortunate for you guys. The first year I haven't done lecture, and I can't even tell you for AP1 lecture in like 10 years. I usually would get all 3 classes, 8 o'clock, 9 o'clock, 10 o'clock. Bang, bang, bang. Same thing 3 times. By the 3rd one, it's like, well, I'm automatic pilot. Just is. Same bad jokes. I insist. Okay. My classes, you had to be able to name or identify the different kinds of joints. Wrists and ankles, flat against flat. Those are the gliding and sliding. The elbow is the perfect, and it's all because of that. If you remember the trochlear surface and the trochlear notch and the ulna, they've got that little ridge in it here, and that doesn't allow wiggle room, so to speak. It doesn't wobble. Only 2 pivoting joints, radius and ulna, radial notch, and the radial head. Here's the radial head. It sits in this little indentation called the radial notch, and the axis and atlas. Those are the only ones that pivot. There's only 2. There are a lot of these. Metacarpophalangeal, your knee, metatarsophalangeal in your foot. They allow not only flexion and extension, but you can move them side to side or rotate them slightly. That's why they're condyloid joints. There's only one saddle joint. That's the one that lets you oppose your thumb. That's the base of the first metacarpal. Okay, with the trapezium. So it's the trapezio-metacarpal joint. It's the only one where it's got like a saddle, and you have the saddle shape on the trapezius, and on the trapezium rather, and you have sort of the reverse of that saddle on the internal aspect or the proximal aspect of the first metacarpal. Ball and socket. Not 34 minutes. Now specific joints. You guys could have a little more enthusiasm today. I mean, other than the home invasion thing, I had no response. A little disappointed. A little disappointed. If I wasn't crazy, it would be wrong. Okay. Specific joints. The 2 we focus on a little bit on the jaw, mostly shoulder and knee. Those are the ones with the anatomy that's significant. And they're the ones that have, interestingly, the most problems that occur with them that are there. The elbow in elderly folks, you see more problems with the elbow. People fall, and a lot of times the wrist will give way or the elbow will give way. When I was a resident a long time ago, we had so many folks, the older folks that were falling, and a lot of fractures. We saw so many different fractures that were there. Okay, so the jaw. Anatomically, for the test, you'll need to remember the jaw. Okay, you have that mandibular condyle, and you have a fossa that's in the temporal bone. So that's a very mobile joint. Plus, so it's basically a condyloid joint in the sense that it flexes and extends. So you can open and close, actually elevate and depress. And because of that disc, now you can do the side to side, front to back, the grinding, the protraction, the retraction of your jaw. Okay, so those are the things that are there. What holds it in place is this very strong lateral ligament. So it can do all of those things, but again, it's very easy to dislocate. Most people know somebody who have what they call TMJ, joint dysfunction, and it's very unpleasant. I mean, it's really tough. And this is that lateral ligament that's quite strong. That's really what's holding it in more than anything else. Inside, where I'm moving the cursor, that's the articular disc. That's what allows it to have all those extra motions. And just like I said before, that's more problems potentially. More stuff when you put more stuff in a joint, more stuff can go wrong. And they're just showing you common because of the shallow socket, always forward, mouth remains open, and it's not easy. Sometimes we used to have to use muscle relaxers. We have to inject somebody with a muscle relaxer. In those days, we used a lot of Valium, intramuscularly or intravenously, and had that come back. We did the same thing for shoulder. We had a lot of dislocated shoulders that we had to pop back into place. All the things that go along with it. A lot of people are helped, and you probably would know somebody who might wear like a bite plate at night, something that you might do if you had orthodontia, but a lot of folks are helped by that. It bothers them less. This is the joint that moves the most. Again, the only thing that's holding your upper extremity to your torso is right there, is that bump here. That's the sternal end of the clavicle and the sternum itself. That has a disc in it as well. But the whole idea, and it's a game. If you have stability, you give up mobility. Okay? If you have a great deal of mobility, then you don't have stability. And that's always the problem with joints. A lot of times, in order to take away pain, we have to take away mobility. That's why we fuse joints or limit their motion. So this is ball and socket, but the idea, and it's a really good analogy, it's like a golf ball on a tee. There's not a whole lot to it. Okay? And the capsule that is normally strong happens to be relatively loose. And so the idea of that is this, and if you remember the anatomy of it when we looked at it, there's a lot of overhangs here. The scapula is strong in the back and strong in the top. And the glenoid is very, very shallow. It tends to dislocate forward and down, anteriorly. We would see a ton of those that would go on. And once it happens once, then it kind of tears the tissue. And if someone isn't careful, it becomes chronically torn, and then you have to have some kind of surgery to be able to deal with it. So it's very, very thin and loose. So it allows motion, but it creates problems that were there. So we used to have those folks would come in, and you had to know what you were doing, because you could really damage nerves going in there. If you did, it's not so easy just to pop it back in. There's a special way to rotate it back into place. that were there. And that's the same illustration you saw before. So this is the one joint more than any other that relies, it's got three muscles, three tendons in the back. They make up a thing that we'll learn about. We talk about muscles called the rotator cuff. There's three parts of it in the back, one in the front. So it's 3 times stronger in the front, in the back, rather than the front. And it relies on this long head of the biceps that acts as a stabilizer. Both the hip and the shoulder, the glenoid, and if you recall, the acetabulum in the hip, rely on something called a labrum. If you follow sports, you'll hear about a lot of athletes that have a torn labrum. That is a cartilaginous, it's kind of like a meniscus, but it's specifically to deepen the socket. It's very important in the shoulder. Okay, again, it goes from being a golf ball on a tee to only about a third. Where do you see the hip? And then there's a lot of ligaments that support it, not a big deal. There's a ton of bursal sacs that are there. There's a lot that goes on. So they're showing you the glenoid, the cartilage. This is ostensibly the reddish thing is the labrum. It's actually a little bigger than that. Then you have, again, the capsule itself. When we learn about the muscles, you'll know that these 4 muscles comprise the rotator cuff. And that's what I mean by cartilage when it's healthy is beautiful, white, glistening, pristine. And when it's arthritic, we would see ones that you'd have to chisel to get arthritis out of, and ones that were so soft, you could almost push on them and you could indent them. So it really is interesting in that regard. Okay, very common to dislocate forward and downward. Okay, arm tackles another way, striking it another way. So I want to go through those without going through all of them. We'll go back and you'll see those again in muscles. The elbow is a very, very stable joint, and it's mostly because of the humerus, particularly with the ulna, less so with the radius. So it's that trochlear notch and the trochlea of the humerus that I was pointing out before. The part that allows you to do this, where the radial head, you saw the illustration, is called the annular. When you see the word annular, it means to encircle. Okay. So annular, there's an interesting condition of the skin called granuloma annulare. We don't even know why. We think it's viral, and it causes like a circular pattern in the skin. Just as an aside, these are the 2 ligaments that are very famous. They are relied. When you talk about a collateral ligament, there's a relatively new needle. Hasn't been destroyed. Anytime you have a ligament on either side, so fibula is lateral, tibia is medial. This is the medial and lateral collateral ligaments. They go from, remember the anatomy, it's not part of the joint, it's called the epicondyle, about what these screws are, from epicondyle to epicondyle. Wherever long bones come together, you have that. So on this, if this is a finger, it would be on one side here and on the other side opposite. Those are what collateral, they are the collateral ligaments are all about side to side stability. You see someone on the side, you used to see it in football games a lot. Now they have that blue tension, you don't see it when they do those examinations. Sometimes they'll do them on the field. They'll be trying to move like at the knee from side to side. Someone will hold it stabilized and move it side to side. So yeah, they're looking for the lateral ligament. The elbow has 2 famous ones, ulnar radial. When you hear about a picture, more commonly else, undergoes Tommy John surgery, or one of the early times where the ulnar collateral ligament, going from the very large medial epicondyle to epicondyle on the humerus, was replaced, and what they did was called autogenous growth. They took ligament tissue from the person's own body, a slip of ligament, without damaging it, and they basically grafted it in place here. And typically the healing for that was a year and a half. They're now doing a surgery where basically they're using an artificial ligament, not so much as a replacement, but as a reinforcement. So there's been some really interesting changes in that surgery. We've had a lot of very, very successful pictures of them. Now they've come back with advances in that surgery. And there used to be a career ender. That particular was named for Tommy John. It was Dodgers, Yankees, and White Sox. And very, for well over 20 years, doing after having that surgery. They named it. So you hear about the ulnar collateral ligament. There's one on the other side, the radial. It's just the nature of throwing. You're not terrible throwing. Not my younger son could throw a baseball like nobody's business, but I'm awful. And as you can see, it's like I said, it's a very snug fit when we look at the elbow. These are the ligaments that are there. So if we're looking from the outside, this would be the lateral or radial collateral ligaments. Here, this is the ulna. Here's the radius. That's that head that looks like a mushroom cap. So on the medial view, now this is the ulna. And it's not just one ligament. There are several little strands that go all along from the epicondyle. But this is the area where that procedure, where that reinforcement procedure is now being done. You remember what the shoulder looked like. The hip, whole different ballgame. Remember the acetabulum. That is a socket. I mean, I make fun of it all the time when I present it to you in class. I mean, that's a socket. You said to your mom, show me a socket. Would you show her that, the one up there in the shoulder? That's not much of a socket. It's a little indentation. That's a socket. Right? Wow. It is so deep, and it has that labrum around it, that it's in there so securely, it's very, very hard to dislocate. You don't have that kind of excursion, a little bit of excursion, do that circumduction. When we would do hip replacement surgery, with a fractured hip, you'd have to take the head out to put a replacement in, to put a metal replacement called a prosthesis. It would make, when you pulled it out, it would make a sound it was like a cork popping. Like if you took a cork out of a champagne bottle or a wine, you know how it makes that very loud sound? Not that you guys would be that terribly familiar with that yet. I don't drink, so I only use it for cooking. Little white wine to deglaze, wonderful pan sauce, little cognac. Perfect. But it's a very deep socket. And they have a really good illustration like that. I mean, that's really healthy cartilage. That is a deep socket. And I mean, the sound would in the operating room, you could hear it. It would reverberate. It was in there. And it took a lot of force. The orthopedic surgeons that I worked with, they weighed more than I do. Big guys. A lot of ligaments sold it. And lastly, and as important as any, the knee. The knee consists of, and looking at the model, it consists of nothing with the fibula. The fibula, mistakenly, even in this text, they talk about the fibula being non-weight bearing. It is not non-weight bearing. It is limited in weight bearing. There's probably 10 to 15% of your weight is borne with the aid of the fibula. It assists it. Okay. You might recall I told you that a lot of times we'll take the fibula and use that for bone grafting and reconstructive surgery. So it's kind of like a spare part. The reality is, but it does not participate in the joint. There's 3 joints. You have the femur and the patella. Okay. That's a flat joint, slides and glides a little bit. You have two other joints between the femur and the tibia because you have medial and lateral condyles. So you have a lateral joint and a medial joint. And what deepens those joints famously because the top of the tibia is relatively flat. And we have any number, you can see another one over there where those rubberized, where it's sort of been disarticulated. These are what the menisci look like. So they create a socket. They train a joint that's odd into really a condyloid joint that allows rotation as well as flexion and extension. So that's the difference in what we see in that particular point. So when it comes to, I don't know if you do it here, this. The internal surface of the patella is cartilage, the external surface of the body. It rises with the femur. So when you bend it, it goes to the bottom of that sort of patellar surface. You straighten it out, it rises to the top. There's a lot of force coming, the tendons that encase the patella come more from the outside, and then the patellar tendon, the knee jerk tendon, kind of goes to the outside. So it's kind of a motion. So the natural tendency is to pull it this way. A lot of people have problems with that. If their foot's not in the proper position, or their leg, if they're bow-legged or not, if their foot is too flat or in a regular position, and to pull that patella sideways. When it isn't sitting properly in the joint, push the undersurface to soften. The famous diagnosis called chondromalacia. It's one of the we see a lot of people. And these interesting because the universal exercise to make these stronger are called straight leg lifts. So you lay on your back, you look on the floor, on the table, or bed, and you do your gesture. You kind of put your toes towards your nose and make this muscle real strong in your thigh, the quadriceps muscle, and you lift it up for 12 inches. You do that maybe 10 times, and you progressively increase the amount of weight. You might start a little bit of weight, get within Velcro ankle weights. You put an object, a strap line, and this. They're called progressive resistance exercises. That's a universal exercise. It's used for that type of thing. So there's a lot that's going on there with it. So you have that joint, which is less important, so to speak, in regard to probably the part where it does the most help you straighten the leg completely. Somebody has a fracture, but a really bad injury, you take out the top. They can't really straighten their leg. You can't walk or run as effectively. But they can still use it. The interior is here. This is where the problems are. You have two ligaments, interestingly enough. The one on the tibial side is adherent, even though they don't demonstrate it here, both to the capsule, to the meniscus, and gets to the cruciate ligaments in a second. The one on the fibular or outer, the lateral collateral ligament, is what's called extracapsular. This is part of the capsule. The intracapsular ligaments are here. You have the anterior cruciate, which goes from medial to lateral, from inferior to superior. The posterior cruciate, which goes the opposite way. So that goes from lateral to medial, from inferior to superior. And cruciate is they crisscross. Cruciform, cruciform. And they both can rupture. They're responsible for internal stability, front to back. So, again, you used to see it more on the sideline than you do today. You have somebody, whoever was examining, somebody would stabilize the thigh, and they pull forward and backward with the knee slightly flexed. It's called the drawer shuffle. So it's like when you have a drawer, normal drawer, you open it and you close it. Whenever you open up a drawer, it's a mess, and when you pull it, the next thing you know, it's all the way out. That's the interior drawer shuffle. So you pulled it too far this way, and all of a sudden you dislocate. And the posterior would be the opposite way. If the anterior, if it has an anterior drawer shine, it means it ruptured the anterior. Posterior drawer shine, posterior cruciate. Both, it's a double portion. So these are things, today, you get an idea in this sport. I mean, everything is sort of subject to MRI technology. advanced imaging, because that's what it's become that way. But years ago, when MRI didn't exist when I was there, it was in its infancy in the early 80s. I used an MRI machine when I was chemistry major in college, 71, 72. Don't start. See, you could add a bonus one. You could look me up. You can't be that old. But no, you're looking up. You too. You're not out of this. You're not. It's okay. My wife's seen all this. I regret. My wife was my student 20 years ago. Don't tell anybody. Don't start in A and P. So a long time ago. So she knows this routine. Sorry, she'd kill me. The ring is cemented on my finger. Cemented. So here's the picture of it. Don't spread this around. I was just joking. So here you go. Anterior is wider in the front, narrow in the back, and the opposite for the posterior. Here are the menisci. They're roughly C-shaped, narrow here as they widen, as they get to, just like you see over there, at the edges. They tear. It's fibrocartilage. It tears relatively easily. That. And they're surrounded by what's called retinacula. In other words, the capsule is not very strong in the front, but there's so many of these fibers, okay, that sort of hold everything in place, where in the back, the capsule is a lot stronger. And so you can see the difference. The medial ligament, or tibial or medial collateral ligament, is adherent to the meniscus. The lateral is separated. And what that does, without looking in the back, and this is what we used to do. Before we had advances, we started using arthroscopy. Now, most knee surgeries are done arthroscopically. We had one that wasn't flexible. We could look in it, but you couldn't really operate with it. So we would look in to identify if there was a tear or damage, and then we'd have to open it up like this to be able to see. And we'd sew it back together. We didn't have all of those advances, and it took a long time to heal. So what happens now is this: collateral ligaments, cruciate ligaments, and cartilages. And typically there's two types. They'll show you the one they show you here. When it's traumatic from the outside, we call it the triad. And this was described before 1960 in the medical literature. Anterior cruciate, medial meniscus, medial collateral ligament. That was the triad of injuries. What we do see a lot today in sport are non-contact cruciate ligament. Somebody twists when they're running, and they twist to avoid somebody, no contact, and they'll go right down. That is usually just the cruciate ligament. That's a little easier. Not that it's easy, but it's a little shorter recovery. So it has a lot to do with whether the foot is planted, whether it gives. There's a whole lot that's involved with that. And then they look at the cartilage, this is what it looks like. So normally it should be smooth. When you get this rough, what you do is you go in, you're looking under direct vision. There's a screen, and it's got ports. So you have one port that's filling it with liquid to expand it, and the other port on the other side, you can introduce like a little burr or a little tiny drill. And what you do is you sort of grind this and smooth it out, and where the liquid's coming in, you can also suck it out. That's what's done. Back in 1985, I had a tear, and it had nothing to do with sport. I was bending over at the Y where my kids were doing swim lessons and left a bunch of toys. The next thing I heard was rip. My boys, they were very little. They were born in 83. My boys were born in 83 and 84. And a sprain versus a strain is a force. A sprain is damage. Lots of different. So, and depending on where they are and the blood supply, so it's what we call a grade 1 is typically microscopic. A grade 2, sometimes you can actually feel or it's more extensive. And a grade 3 is almost like it's torn in two. And so there's a lot of different things that are involved. When you hear the term dislocation, the medical term is luxation. When I go to the chiropractor, and I do that every 2 weeks, it's called subluxation. The joints are a little out of place, not dislocated. And what the chiropractic adjustments are trying to put that back into place. And I'm not going to, the arthritis nugget, which I could spend all day talking about, is not something I would talk about. That's for me, it's lecture. Did you get to arthritis yet? Arthritides, look, most of us, you get somebody who's my age, they have the numbers here. It's called osteoarthritis or degenerative joint disease. It's basically where by age 85, half of us have it. Women more than men. Most of us have it. It's there. And it comes from whether you had an injury when you were a kid. Anytime you damage a joint, over time, there's signs of deterioration. You're fortunate if you don't have it. My brother-in-law is 80 years old. Just kill him. Can shoot his age on the golf course. He's one of those. First guy chosen, choose up teams, the first guy. Basketball, great dancer, plays musical instruments, all that talent. He and my sister have been married for 55 years. He can still hit a golf ball, 250, 270 yards. My back is so bad I can even play it all this year. It's you don't know what brings it. A lot of it's hereditary and things like that. Wear and tear, enzymes, cartilage breaks down. It doesn't repair. You get little pieces of bone. We call them joint mice. They're really calcified cartilage. Like in that model, they jam things up. They get stuck in those pleats. All of that makes sounds. It's stiff. There's lots of ways to treat it. This is immunological. Inflammatory. They both are inflammatory. We take anti-inflammatories. But when they talk about inflammatory arthritis, it's because there's an immunological component, which means whether it's antibodies or white blood cells, something in your immune system is attacking you. Unfortunately, I have that too. Can't win. So I take, and I did one on Saturday. I do every 2 weeks. I take this. It's called Humira. What does Humira exactly do? It blocks something that you'll learn about in AP2 called tumor necrosis factor. That's what the TNF is. So certain autoimmune diseases to stop that and reduce inflammation. Okay. So there's a lot of these. People use it in Crohn's disease. I have a variation in this family. It's actually a variation of what's called psoriatic arthritis. And I didn't have that until maybe about 8 years ago because they were treating my bladder cancer with immunotherapy, and it kind of caused like a firestorm. That's designed to increase your immune activity, but what it did is it kind of threw mine over the ledge. So I mean, so there's a lot of nuances with that. So I don't go into it here in the lab. That's for lecture. If you have any questions regarding what you're going over in lecture, or any clarification that I can help with, I work with Dr. Robbins all the time. I know Dr. Stanton. So I'm sure you have, there are only two folks who are doing lecture, correct? So you either have Dr. Robbins or Dr. Stanton, correct? Okay. Okay, last thing. A little nugget or two on the bones for you. This is the lecture program is over. Bones out if you want to take a look at them. Here's what I'll be doing. I just put new printer ink in my printer at home. Okay, so I print up a lot. I'll have bones out, like you can see with some of the labels that are on there. I will also, not for all of these, I'll have images as well, because you can label the bones, but the tape doesn't stick particularly well. And so most of these, it's going to be, we'll probably have about 20 or 22 stations, and it'll be 3 responses. Typically, it's name the bone and name 2 features, and some of them, if we use the same bone more than once, which we easily can, it might be just name 3 features. Okay, so that's what you're sort of prepping for. Feature, femur, greater this is the femur, greater trochanter, lesser trochanter, medial condyle, humerus, trochlea, head, whatever. That's the feature. So name the bone. That's typically the question. And because there's so many of us, we kind of have to play musical chairs. But then you have plenty of times afterwards to go and check your answers. So it's not a time limit. And I don't care about lefts and rights. Don't drive yourself nuts. What? No, you can't work together. But I'll make a one-time offer. You can bring a piece of paper as a reference.
How big is a piece of paper?
Oh, you're terrible. Standard 8.5 by 11 paper.
Front and back.
Yeah, front and back. It is not a bad word sheet. It is a reference paper. Not that C word that ends in eat. We don't use that word in the class. You may have that with you. Other than that, when you walk in, I know, all of a sudden you're like, oh my God, I won't have to spend all weekend studying. That's so you can watch the Steelers game at 4 o'clock on Sunday. So for instance, I will probably use this, and I'll circle like one of the bones and ask you, or maybe I'll circle, like with this one, yes ma'am.
Wait, are you going to have like a piece of paper with a bone on it, or are you going to have like a bone?
I will probably both. If I can, both. If I can't, just I will not have an image at every station, but I may not. Yes, go ahead.
On our reference guide, can we have pictures like that?
Yes.
Oh my God. Yes, we are.
I don't like anybody.
You love it.
Just saying. So I wouldn't use that one. I'm just going to show you the ones I typically use. Okay. I sometimes will use, it's hard with the occipital bone, but so I may use an under, I use this, and I print them in color if I can. If I forget, like, I can only print black and white here, but at home I tend to print them in color. I'll have that image. I'll have this image. Okay. I do not have an ethmoid bone, so when you have this one, I'll only have one image. I'll have this or that. And let's see. There's not a whole lot. I definitely have the jaw. I may have an image or not. With the mandible, might have that. But I use that rubber model for these, for the facial, more than anything else. Okay, so there's not a whole lot there. This is 7A. So they're all coming from 7. So I just make your life easier. Okay, the hyoid is not on there. That's more with muscles. Okay, so I don't include that. One of the questions you're going to have to name bones of the orbit. There are 7. No, at least 3. There's 7.
I got it. Hold on.
There's 7. You don't even have to bat 500. 3 out of 7. Can I? Yes. Would you like me to do that for you? Yes. Frontal, ethmoid, sphenoid are cranial bones. Frontal, ethmoid, sphenoid. See, I passed the test. Facial bones are zygomatic, which is kind of your cheekbone. Lacrimal, that bump that's in here. Okay, maxilla or maxillary bone, your upper jaw, and the one that you can't, the oddball is the palatine. That's the one that's kind of like way in the back. It's a good thing I know this. So yeah, okay. And nothing else there. We're not done yet. I'll show you the other images. Then we're going. You know, this is B. Okay. Yeah, I'm listening. Oh, 15 out of 15. There are two quizzes. There'll be a quiz, probably a quiz that has to do with muscles and maybe the joints. And yes, and that'll be another 15 points. So whatever points you got. So if you got, there were 50, so many of you got like anywhere 13, 14, 15. So everybody did pretty good. It's take home. You're supposed to do good on it. Right? It's a 1 credit lab. Lecture isn't that easy, is it? No. Right. In general, okay. Most of us in science, lecture is designed, is sort of, that's where you really have the difficult stuff. Lab is fairly straightforward. Not every lab, but when you get into advanced levels. But you guys are going to have, many of you guys are going to have micro lab and A&P2 lab. Okay, next term. And so that's challenging. The AP2 lab isn't as bad. The micro lab, there's a lot to do in regard to that. I am not teaching the micro lab. Okay, moving on. So let me back up. Oh, I didn't mean to do it that way. Here. I'll show you the illustrations I use. That one. Okay. Pardon me, yeah, that one is on there. A lot of times I'll have the bone and the illustration next to each other. Okay. You will have to be able to identify what cervical, okay, thoracic and lumbar. So I'll have 3 vertebrae out there from the 3 different regions. You have to know why. They're different. This is the big player is here. Remember that one goes downward. This one's short. They're big, wide, like a hatchet. And then the cervical ones always have the transverse foramen. The atlas and the axis will be on there. They're very distinctive. Remember, the atlas has that. It's like a ring of bone. And again, you see the transverse foramina. And the axis has that thing that sticks up, the dens or odontoid process. It looks like a tooth. Like somebody had just one tooth in their mouth. I am missing something that I usually use. And I don't generally put the sacrum on it, just telling you. I have to use this illustration. I don't know where, I'll see if somebody misplaced it or moved it, because I usually use the model and the illustration. But right now I have to print up the illustration for that. So you'll need to know the different parts, manubrium, body, xiphoid, etc. That'll be on there. You should be able to identify a rib just in generically speaking. So I'm not going to have any illustrations per se like that. But if someone looks like that, it's a rib. Yeah, just say rib. It doesn't have to be. No. Generally, I'll have like some of these will be like I'll have 3 bones. You know, this is a rib, this is a clavicle, this is a mandible. So sometimes it may not be just bone and feature. It may just be named that bone. Okay. You can handle this. The fact that you have a reference sheet should not preclude studying.
True.
Just trying to be helpful. Last, yeah, I know. Money, we take cash. Or checks made out to cash.
I would take my tuition.
What? I'm just joking again. I'm not asking the students for money. Ha ha. Oh, wait. One more thing. Hey, look, now that I'm popular. Oh, hold on. You'll love this. Yeah, you'll love it. You'll love this. Is that a great picture or what? It's my eldest and his daughter at the Jacksonville Jaguars game Sunday because they live in Jacksonville. He's the Navy officer.
Do you have a favorite president?
No.
You're lying.
No.
Everyone has a favorite.
No.
Do you have like a preferred?
No.
Okay.
No.
What about a favorite child?
No. They're all evil. They're all a pain. The guy, I have a granddaughter who's older than you guys.
How much?
22.
I'm
22 year old. I have a 22-year-old grandma. Now on pictures, this is a picture. That's Cloud. He's the cat in charge.
He looks like it.
He's a. It's like if he wants out, you have to let him out. If he wants in, you have to let him in. It's like, but you see, I see a cat in charge. The other cat's not nearly as in charge, and the dog certainly. It's like, oh God, these cats. Moving on. Last thing. Pardon me. You had to see the dog. You've all seen the dog.
Are you sure?
Pardon me.
Can we see the other cat too?
I'll have to. My wife is supposed to send me some additional pictures. She's much better at pictures than I am. It's a very nice looking cat.
Are we allowed?
Yeah, only if you want to.
Are we going to?
Yeah, here. You want to see the egg? Then I got to finish up the last part with the bones. Here. The dog.
What's the dog's name again?
Lincoln.
Lincoln. He's so handsome.
He is a good looking dog. He's just not the smartest dog in the dog drawer, if you know what I mean. He's not brilliant. He's not brilliant. Fetch. Fetch what? Okay, now. So, clavicle, may use this, clavicle, scapula, so you know that that's a two-bone assembly called the pectoral girdle. Okay. The collarbone I would just use as a collarbone. I wouldn't ask for any of the anatomy. Either of those. There's just not enough to me. I do use this. There's a lot of anatomy on the scapula. So you have the acromion process, the coracoid process, the glenoid cavity, and the spine of the scapula, your shoulder blade, plus these surfaces, supraspinous, infraspinous, subscapulars. You'll probably see that twice. At least you'll see questions about the scapula twice, I would think. And the humerus, certainly at least once. So typically I print both of these together. So you'd know the head, the greater and lesser tubercle. You'll be able to see the trochlea, the capitulum, the medial epicondyle is very distinctive. Okay. So those are, you would easily see that. And you could use this the same way. There's the acromion process, the head of the radius. And the same thing with the bones here. There's a fair amount of anatomy, olecranon, again, the radial head. There's an area which you can't see it quite as well here, the radial notch. So I'd put those as companions in regard to that. And you'll definitely see this. Know those bones. There's 8 bones I can ask questions about. I don't use this per se. There's enough anatomy here. So you have the 3 different bones, the ilium, ischium, and pubis. You have the acetabulum, the greater sciatic notch, the obturator foramen. So you can easily get two 3-part questions out of that, either side. And I won't do anything. I'm not going to do anything with, is this male or is this female? That's not part of the course, really. It's interesting, but it's not part of it. Again, a lot on the femur. Femur's got a lot of anatomy with it. You usually have 2 questions with that. And then the tibia and the fibula, like I said, typically you have the tibial tubercles, tibial tuberosity, medial malleolus, lateral malleolus, head, and it's easier if they're together. And with most of our specimens, we have both of them together, like that, and whatever's on the foot. And that's everything. None of the arches. But the bones of the foot, yes. So when we go backwards, particularly talus, calcaneus talus, navicular cuneiform, navicular cuboid, and the cuneiforms. Okay, that's it. Now we're done. You want to look at the bones? I'm here for a bit. You want to look at, Friday or Monday? I'm fine with that.
What's the latest you'll be?
On which day?
The latest you'll be.
Monday?
Yeah.
Monday I will be here. I'm in this lab pretty much continuously between 3 and 5. So I'll open the lab at 2. We're at 1. So all afternoon.
Okay, thank you.